Good morning once again, everyone, and welcome to today's webinar. Today's topic is a look at senior care options, and we are so thankful you decided to join us today. These complimentary webinars are brought to you through a collaboration of sponsorship through O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, and Chatterton and Associates, the Wealth Management Team, as well as us here at Alzheimer's Orange County. My name is Melissa Klabe. I'm the Director of Education here at Alzheimer's Orange County, and it's my pleasure to be your host today. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial for anyone who cares for and works with older adults, and we do hope you find today's presentation informative and useful. And today our presenter is the lovely Nikki Barrett. Nikki Barrett, LCSW, is the social work supervisor here at Alzheimer's Orange County. She is a licensed clinical social worker with a master's degree in social welfare and a Bachelor of Arts in Psychology with a social work minor. And prior to her position here at Alzheimer's Orange County, Ms. Barrett was a care planner for the Independence at Home program at SCAN Health Plan, care manager for the City of Irvine Senior Services, and a resident services coordinator for Jewish Federation and Family Services in Irvine. Ms. Barrett is passionate about assisting older adults with care coordination, particularly for special populations impacted by dementia. And I'm going to go ahead and turn it over to Nikki.
Thank you, Melissa, for the introduction, and thank you everyone so much for joining us today for this presentation. I'm really excited for the opportunity to share with you what I have learned through working with older adults and their caregivers. So the goals for today are that you will gain a clearer understanding of what kinds of care options exist, how Medicare differs from Medi-Cal, and the cost of care. And the information I'm presenting today, I learned over the course of time through working with clients, trying to help them navigate their benefits, probably hours on the phone with service providers and various trainings. So in whatever role or capacity you have joined us today, whether professional or personal, I do hope that the knowledge you gain aids you in some way in planning for a client or a loved one or even yourself. As I'm sure many of us can attest to, there is an ever-growing demand and need for elder care services. And it's no wonder given how the demographics of our population are shifting. The number of Americans aged 65 and older is projected to nearly double from 51 million in 2017 to almost 95 million by 2060. So the 65 and older age group share of the total population will rise accordingly from 16% to 23%. Now, the aging of the baby boom generation could also fuel more than a 50% increase in the number of Americans aged 65 and over who require nursing home care, from 1.2 million in 2017 to about 1.9 million in 2030, which is really just around the corner. The demand for elder care will also be driven by a steep rise in the number of Americans living with Alzheimer's disease, which could more than double by 2050 to 13.8 million from 5.6 million last year. And all this to say, it really is a sobering reminder of just how direly services are going to be needed, not just in Orange County and not just in California, but across the entire country. And the implications of all this are also incredibly significant for our caregivers. And in this line of work, we frequently hear the quote by former First Lady Rosalind Carter that there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. And what we know for caregivers of those with Alzheimer's disease or other dementias is that a disproportionate number of caregivers are women, 2/3 in fact. And 1 in 3 caregivers are 65 or older themselves. And sadly, many caregivers will actually pass away before the person they are caring for due to the physical, emotional, and psychological toll that caregiving can take. We also know that 41% of caregivers have a household income of $50,000 or less, And perhaps significant more than ever to today is the number of what we call sandwich generation caregivers. About 25% of caregivers are sandwich generation caregivers, meaning that they are simultaneously caring for a parent or older relative while also caring for children and minors under 18. I recently heard a fellow professional allude to the dilemma of sandwich generation caregivers of will they be able to send their kids to college or pay for mom and dad's nursing home, which really struck me. So in 2018, caregivers provided 18.5 billion hours of informal, unpaid care, meaning they weren't professionals with an agency or any other kind of program. These were family members, perhaps community members, involved in the care for someone with Alzheimer's disease or dementia on their own dime. And all those hours of care were valued at a staggering $234 billion. And what we often see is that caregivers, especially of working age, needing to take more and more time off of work due to the increasing care needs of a loved one, may eventually have to quit their jobs altogether before they're ready to retire. And this financial toll, combined with the impact on physical and mental health, can take on an avalanche effect of sorts, which has long-lasting implications for the aging process and quality of life for those caregivers as they then enter into this stage of life. So now I'll go into the types of care options available, and keep in mind that these levels of care exist on a continuum, and there is not a one-size-fits-all for every individual or family. And among other things, there are generational, cultural, and financial factors that greatly influence the decision-making process. And I believe that one of the most important things that we as professionals can do when addressing long-term care planning is really respecting where the individual and family are at. These are not easy decisions to make. The kinds of changes and transitions that lead up to utilizing these services can very much be associated with a loss of independence. So as positive and helpful as these resources have the potential to be, we still want to acknowledge what it might have taken for a person or a family to ask for help in navigating these resources. So the care options that are based in the home or community include in-home care, home health care, and adult day health care. In-home care is very significant because more and more people do wish to age in place in their own homes. And one of the ways they can do this is with support of a caregiver. And a caregiver can assist with both activities of daily living, ADLs, and instrumental activities of daily living, or IADLs. And ADLs pertain more to personal care needs such as bathing, dressing, toileting, transferring, and feeding, whereas IADLs pertain to the essential day-to-day tasks and errands such as shopping, meal preparation, housekeeping, transportation, medication management, and financial management. So you may hear the terms personal care, home care, custodial care, or even companion care in reference to support for these tasks. And it is important to note that this is not medical care. And if there is a need to address medical care in the home, one of the ways can be through the support of home health care. And this could serve as an alternative to hospitalization, given that the illness or injury can be managed and stabilized at home. Home health care does require a doctor's orders, and it is generally time limited. And examples of treatments that could be provided through home health care would include wound care, IV treatments, nutrition therapy, physical therapy, occupational therapy, medication monitoring and management, as well as caregiver education. So as home health nurses, physical therapists, occupational therapists, and home health aides come to the home, they're not just providing these services or interventions and leaving, they're also teaching how to manage care and sustain those interventions as well. Adult Day Healthcare, or ADHC, is an outpatient daytime program that offers individuals with chronic conditions or disabilities a structured environment, including meals and activities. And this can help promote aging in place safely and independently as an alternative to hospitalization or skilled nursing admission. And there are two different models of care. The medical model may include nursing, social services, physical and occupational therapy, as well as speech therapy. And the social model is appropriate for those who may not need so much of that coordinated medical care, but would still benefit from the structure, supervision, activities, and socialization. And some adult day centers are specifically designed and geared for addressing the needs and progression of Alzheimer's disease and related dementias. And I also want to mention that many individuals can and do benefit from some combination of the types of care discussed so far. So for example, an individual may attend an adult day health care center a couple days a week while also having a part-time caregiver for additional support another few days a week. Okay, so now I'm going to go over the care options that entail placement. And so residential care facilities for the elderly, otherwise known as RCFEs, are licensed and regulated by the State Department of Social Services Community Care Licensing. And they generally encompass room and board, housekeeping, supervision, and personal care for a monthly fee. However, they are not medical facilities. Assisted living facilities, board and care homes, memory care, and continuing care retirement communities would all be examples of RCFEs. And we get many questions as to what the differences are between these types of RCFEs or which one is best for my loved one. And again, it isn't that cut and dry nor universal for everyone. And we do encourage people to consider not only the level of care their loved one needs, but also budget, geographic location, and so many other factors when considering the type of facility that would be the best fit. Skilled nursing facilities are also held to license and operating regulations, but are different from RCFEs in that they are healthcare facilities and do provide medical care. So skilled nursing facilities are staffed by providers across multiple disciplines, including physicians, nurses, pharmacists, dietitians, physical and occupational therapists, social workers, and more. And individuals are generally admitted to skilled nursing facilities for shorter term rehabilitations, let's say following a hospitalization or a major surgery, but sometimes they can also be admitted longer term. And when we say that someone has a skilled nursing need or a skilled nursing level of care, it means that that level of care or that need can only be met and provided by a licensed nurse. Continuing care retirement communities offer the varying levels of care in a central location. And residing in a CCRC entails what the State Department of Social Services defines as the following. It is a long-term continuing care contract that provides for housing, residential services, and nursing care, usually in one location, and usually for a resident's lifetime. So an individual who transitions from independent living to assisted living and later memory care or skilled nursing care within a CCRC, they could transition from perhaps one building to another or one end of a large campus to another within the same community, as opposed to having to move across towns or across cities as their care needs evolve. And there are various levels and types of contracts and an entrance fee in addition to a monthly fee. And as of 2014, there were approximately 100 CCRCs licensed in the state of California. And now that we've gone over the various types and levels of care and the care options, I'll review the costs of care. And keep in mind that these following figures are median figures for the state of California and also from 2018. So for areas of California that have higher costs of living, such as Orange County, the median would be expected to be higher than the overall state median. In 2018, the median cost of in-home care in California was $26 an hour. Now, unless an individual qualifies for in-home supportive services through Medi-Cal or has a long-term care insurance policy, this would generally be an out-of-pocket cost, not otherwise covered by health insurance or Medicare. And in 2018, the median cost of adult day health care in California was about $78 a day. And again, unless an individual qualifies for a waiver through Medi-Cal or perhaps Veterans Affairs, this service would also be an out-of-pocket cost, not generally covered by insurance. And in 2018, the median cost of RCFEs in California was $4,500 a month. Now, Medicare does not cover RCFE costs. However, for those that have Medi-Cal, there is something called the Assisted Living Waiver Program. And among other qualifying criteria, an individual would need to have Medi-Cal with no share of cost, or what we call full scope Medi-Cal. And I'll explain more a little bit about that later. And also have a skilled nursing level of care need. And the idea is to provide options to reside in an RCFE or public subsidized housing as an alternative to long-term placement in skilled nursing. And there is also a financial qualification for the assisted living waiver program, and the monthly rate for it would entail most of that qualifying person's income and leave a fairly small personal allowance. And that monthly rate would then cover room and board, custodial care, meals, and care coordination. And the program did reach capacity a few years back and has had lengthy waiting lists since then. So for skilled nursing, as of 2018, the median cost was about over $8,000 a month for a semi-private room. And Medicare will pay for skilled nursing when several very specific criteria are met. And these criteria are outlined on the Medicare website. And even when all those criteria are met, the number of days and the extent of coverage are very clearly defined. And so for days 1 through 20, there is a $0 coinsurance. For days 21 through 100, there is a $176 daily coinsurance. And any stay exceeding 100 days is full cost responsibility on the part of the individual. And Medi-Cal, on the other hand, will pay for SNF when medically necessary. However, it's important to note that the facility must also be licensed and certified by the State Department of Health Services to receive Medi-Cal funding. Now, these figures we have here for the costs of CCRCs are from further back than the previous figures we've just reviewed. In 2019, the entrance fees were at least 6 figures, which they probably still are. And again, as I mentioned earlier, there are varying levels of contracts for CCRCs, and so the monthly fee would likely vary somewhere in this range. So I know that I've been mentioning Medicare and Medi-Cal quite a lot in the last few minutes, and so I just want to take some time to explore the differences between the two programs, and hopefully that will help to start bringing all of this together. So Medicare is a federal program, and the benefits, generally speaking, are associated with turning 65. And for a time, that went hand in hand with retirement and Social Security benefits. But given the rising minimum age for full retirement benefits, people are choosing to work longer or having to work longer, and they're thus likely to qualify for Medicare before they even begin to access their retirement benefits. Now, prior to 65, someone who has been receiving Social Security disability benefits for 24 consecutive months will also qualify for Medicare coverage. Now, Medi-Cal is California's Medicaid program, and qualifying for Medi-Cal is income-based regardless of age. That said, the income eligibility does differ for those that are younger than 65 than for those that are 65 or older. And to help distinguish between the two benefits, sometimes even just looking at the cards can help. And so the Medicare card is, as you can see, red, white, and blue. It is printed on paper. The most current versions no longer have the beneficiary's Social Security number as the ID, but rather a generic series of letters and numbers, which was changed in the interest of protecting privacy. And the Medi-Cal card is white and blue, and sometimes it will have our California state flower, the poppy, on it, and it's printed on plastic and labeled as State of California Benefits Identification Card. And I should also mention that in Orange County, CalOptima is the managed care entity that administers Medi-Cal benefits. And so Orange County residents may additionally have their own CalOptima member identification card. So at this time, I'll break down a little further what constitutes Medicare. Now, original Medicare consists of two parts, Part A and Part B. Part A covers hospital insurance, which encompasses inpatient hospitalization, skilled nursing, hospice, and home health care. For those that have enough work credits and qualify for Social Security retirement benefits, there's no premium for Part A, and enrollment is usually automatic upon turning 65. Now, for those that do not have enough work credits and thus do not qualify for retirement benefits, there is a premium for Part A and one must usually self-enroll. Part B covers medical insurance, which encompasses doctor's office visits, medically necessary services, and preventive services. And for Part B, there is a monthly premium regardless of work credit status. And last year, that premium was about $135. This year, it is $144. And that is a monthly amount. It's generally deducted from one's Social Security benefits check, and those who qualify for Medi-Cal may have their Part B premium paid for. And it is also important to note for both Part A and Part B, there can be penalties for late enrollment. And when that happens, the premiums can increase a certain percentage of the standard premium for every 12-month period that someone qualified for those benefits but were not enrolled. Now, there are situations where a person may be able to delay or defer coverage without penalty, and the Medicare website does go over those details in specific scenarios. And again, going back to the point of individuals working longer, it's not unheard of that people would turn 65 and thus qualify for Medicare Parts A and B, but don't necessarily need it yet because they may still have employer health care coverage through either their own job or a spouse's job. Okay, so Medicare Advantage, MA plans, also known as Medicare Part C, is essentially a combination of Parts A and Part B offered as one package through Medicare contracted health insurance companies. So among other options, there are HMO, PPO options available to beneficiaries who would elect for a Part C. And some health plans may charge an additional monthly premium while others may not. And some health plans may even pay part or all of one's Part B premiums. Now, Medicare Part D pertains to prescription drug coverage, which is separate from Parts A and B. So there is a separate monthly premium for Part D depending on who the plan provider is and also one's income level. Now, Part C or Medicare Advantage plans will likely include a prescription drug coverage in that comprehensive plan anyway, and that may be referred to as a MAPD plan. So with all that said, I just want to touch briefly on the point that there's a common misconception that working and paying into Social Security and Medicare ensures coverage for just about anything you might need in retirement. And as you can see, when we break down this information, that's not exactly the case. And so I cannot emphasize enough just the importance of staying informed, asking questions of your providers, and planning ahead. So I won't go over all of these for time's sake, but as you can see just from the slide here, Medi-Cal services are more comprehensive in some ways than Medicare. And I'll go over next the few ways that people can qualify for Medi-Cal services. So individuals who have very limited income and limited resources who qualify for Supplemental Security Income or SSI, they are automatically enrolled in Medi-Cal. And I do want to note that I see some varied figures out there when it comes to SSI. There are very, very strict income limits and calculations and formulas pertaining to SSI benefits. But the important thing to know is that if you qualify for SSI, you are automatically qualified and enrolled in Medi-Cal. All right, so for individuals who may not qualify to receive SSI, but are still 65 or over or living with a disability, There's something called the aged and disabled federal poverty level. And so the asset limitations, well, first the income limits, as you can see, are a little bit higher, about $1,200 for single, $1,700 for married. And the asset limitations you see listed here, $2,000 and $3,000 respectively, do have some exemptions. So there are personal property items that would not count against that asset limit. And that list gets pretty specific, but some key items to note are that one's primary residence and one vehicle would not count against that asset limit. So then for those that don't meet the criteria to qualify for Medi-Cal in the previous two variations, there is another option known as Aged, Blind, and Disabled Medically Needy Program, which is quite a mouthful. So Medi-Cal share of cost is usually the way that we refer to it. So share of cost is not a monthly premium, but it acts more like a deductible. And so that share of cost has to be spent down in a given month before Medi-Cal benefits would then kick in to pay for any remaining costs. So we call that a spend down. And that can be accomplished through either paid medical bills, unpaid medical bills, purchasing additional health insurance premiums, and more. And earlier I mentioned that for the assisted living waiver program, one of the qualifications is that an individual has to have Medi-Cal with no share of cost or full scope Medi-Cal. So individuals who have Medi-Cal with the share of cost may not necessarily qualify for every Medi-Cal benefit, or they may just have that larger out-of-pocket cost. And there are a lot of nuances as to how share of cost is calculated, but it essentially comes down to countable income minus something called the maintenance need level, or MNL. And I have those figures up here, 600 for a single and about 900 for a couple. And how much income is considered countable depends on whether the sources of income are considered earned or unearned. So examples of earned income would include wages from a job, and examples of unearned income would include Social Security or other retirement benefits. For unearned income, there is also a $20 allowance that is factored into the formula. And so once that countable income is calculated, the maintenance need level is subtracted, and that becomes that individual's share of cost. Now, the maintenance need level is pretty low, and that does impact how share of cost is calculated. So it's not uncommon for share of cost to be hundreds of dollars, and this maintenance need level was set back in 1989, but it has not been adjusted to account for increased cost of living. And I'll talk for a moment about spousal impoverishment laws. Now, these were enacted back in 1988 with the recognition that the cost of long-term care for a spouse could very quickly deplete resources of a partner living at home in the community. And so the community residing spouse is referred to as the well spouse, and the well spouse is permitted to retain approximately $3,000 in monthly income, in addition to approximately $126,000 in assets. So as you can see, that's significantly more than the typical ways to qualify for Medi-Cal. And this would generally apply to skilled nursing placement. So the well spouse would continue to reside in their own home in the community. The spouse who has that level of care, that need, would be placed in a facility, and then the spousal impoverishment laws could be applied. But sometimes that can also be applied to home and community-based services and other waiver programs. So I hope that the information today has provided you with a better understanding of care options and coverage, but if there are times that you still feel like you have more questions than answers as you go, you're certainly not alone. And so I did want to share some of these resources to start, and these can be very complicated systems to navigate. And Again, these are just a few starter resources, and the sources for today's presentation are also listed on the next slide, but also in the handouts. And you can also call our helpline if you are in need of more information. For Orange County, we have a list of placement specialists as well as elder law attorneys who can help navigate these matters. And our care consultants are, at the ready to offer additional support and resources for more specific questions.
All right, that was packed full of information. Thank you so much, Nikki. We have lots of questions, so I'm glad we have some time. I want to remind everyone that they can type in their questions, and I want to take this time to thank our sponsors one more time. If you wouldn't mind going to that next slide, Nikki, I think. There we go. Chatterton and Associates, the Wealth Management Team, O'Connor Mortuary, Care Choices, Hospice and Palliative Services, and Caring Companions at Home. We are grateful for your support to be able to bring these webinars to the community. And I'm going to get right into the questions here. We have a couple questions about specific adult day centers in Orange County. One was asking, where in Orange County are there medical model daycare centers? I don't know if you want to speak to that or direct people to our helpline too. Yeah.
Yeah, so if you'd like to call our helpline, it's 844-435-7259, and it's option 2 for Orange County. We have a list of adult day centers in Orange County, all throughout Orange County, and some centers will operate both models, and so it just depends on what city and what region you're looking, and so we'd be happy to provide that list and then kind of direct you to start with what's closest and go from there.
Great. Yeah, there was another question, same kind of in the same vein of where are there social models near Fullerton? And they also asked, is there any help through SCAN insurance plans? I don't know if you want to speak to that.
Yeah, so if you or your loved one is a part of a Medicare Advantage plan like SCAN or through other providers, I would really encourage you to call the member services or customer service representative. Usually there's some kind of contact number on the back of the ID cards or on most of the paperwork that comes through. And so if you call and inquire about the specific benefits for the specific beneficiary, that can be helpful. And so, and again, ADHD centers are all spread throughout Orange County, LA County, and beyond. And so we have a list specific to Orange County and would be more than happy to share that for those who need it.
Great. Next question, is it correct that the individual must have a skilled need to qualify for the medical waiver program?
That is correct, yes. And so not only do they have to have a level of care and a need that is similar to those residing in nursing homes, they also have to be have the capacity enough to reside safely in an alternative placement setting for the assisted living waiver program.
Okay, and this is kind of similar, but somebody else asked, can you apply for the Medi-Cal assisted living waiver years before you need it?
It's the timing of it is kind of a double-edged sword. And so I think the wait lists right now exceed 12 months. And so it is prudent to go ahead and apply early. But then it would just kind of be a gamble of by the time you get towards the top of the wait list, will you be ready to make that transition? And so there you can apply through the Department of Healthcare Services website. There are several what they call coordinating agencies that kind of take charge of helping coordinate applications for specific regions.
Okay, great. Somebody asked, did I possibly miss the definition of what Medicare Advantage is? I know we had a slide on that. Do you maybe want to give a quick recap?
Sure. So Medicare Advantage, otherwise known as Medicare Part C. And so basically it's a combination of Medicare Part A and Part B, and it's provided through Medicare contracted health insurance companies. And so there are HMO, PPO options available to beneficiaries who might be interested in a Medicare Advantage plan, keeping in mind the open enrollment periods. And so If you're interested in all the types of plans that are available, at least in Orange County, you can call HICAP at the Council on Aging and ask for a consultation. They do get tremendously busy around the open enrollment period, so maybe a little bit before that, if you're someone who's looking to make a change, or if you're becoming newly qualified to enroll in Medicare, HICAP offers the free counseling services to go over all of your options on the table.
Awesome. Okay, here's one you may or may not know. Is there any state program that may pay for private RCFE?
You know what? I'm not entirely sure about that, but again, if you want to call our helpline, that is something that we could explore together and try to guide you in the right direction.
Okay, great. Here's another question. How does a family member get paid to be a caregiver?
Yeah, so the in-home supportive services program, which I briefly mentioned, but I didn't go very much into it earlier, is one of the ways that family caregivers can become a paid caregiver for a care recipient. But the contingency there is that that person has to qualify for Medi-Cal. And so if a person does qualify for Medi-Cal, what they can do is call the Orange County Social Services Agency and apply for in-home supportive services. And what will happen is a social worker will come out to the home to do an in-home assessment and evaluation of the care recipient's physical needs and capacity. And they'll determine a specific number of minutes that it takes to support that person with a given task. And so then all of those minutes are tallied up, and it comes out to a total number of monthly hours that that person is authorized for. And then it would be a matter of ensuring that the family caregiver, or sometimes a friend, a neighbor, whoever else the person desires, would attend a 4-hour training and orientation, go through live scan, fingerprint, background, and then do all the paperwork necessary to get paired up in their system as that person's designated caregiver. And then from there, it would just be a matter of staying on top of the submission of time cards. And there is an annual reevaluation for in-home supportive services.
Okay, great. Thanks for that info. We have a couple people asking to repeat the helpline number, if you wouldn't mind.
Yeah, no, of course. It is 844-435-7259. And you're going to hear a couple different options for the various regions. We do share that number with Los Angeles and other counties. And so you're going to want to press 2 for Orange County to be linked with us here.
Great, thank you. Okay, here's a question. Do you have info on when there is a life-changing event, such as a move to a different area, how someone might go about changing their insurance company?
Yeah, and so things like this happen. So sometimes you move across counties, across states. For private insurance, like or Advantage plans, I guess it would be a matter of whether they provide coverage in different regions. For Medi-Cal, what we see a lot is that there's a challenge when somebody is transferring across county lines, so from Inland Empire to Orange County or LA or vice versa. And so it's really important just to be in communication. And what I always tell my clients is to really just keep a record log of who you're talking to, where they work, ask for a reference number for conversations, and just try to do your best to be in communication with those people to ensure that the transfer of benefits goes over smoothly.
Okay, great. Okay, question. When attorneys promote Medi-Cal planning services and advise clients to spend down all their money so they can go to a nursing home paid by Medi-Cal, why do they not explain that it won't be possible unless they have a skilled need? Any insight?
Yeah, I think that the information surrounding this is just so convoluted that even amongst other, across disciplines, there's not always a consistent understanding about all the nuances of this. And so, nursing homes are not just for anybody and everybody to go. Again, they have to have something that is going on with them physically that can only be met and addressed by the skilled care that a licensed nurse can provide. And so something to just kind of keep in mind is when in doubt, maybe get a second opinion, talk to other professionals or providers that you're working with across other disciplines, and just ask questions, ask a lot of clarifying questions. And on the note of spending down, it's not quite as simple as giving away all your money and assets and then stepping right into a service or a facility. There is what we call a look back period. And so for a certain period of time after somebody might gift some assets or money, they still won't qualify immediately for Medi-Cal services.
Okay, thanks. And this kind of goes in that vein. It's more of a comment. Someone's kind of commenting there isn't really an income limit in Medi-Cal. Anything over the maintenance need gets determined to be a share of cost. Some Medi-Cal programs have an income limit, but basic Medi-Cal does not if all other factors such as residency and property limit are met. So I don't know if you want to speak to that.
Yeah. I'm sorry, could you repeat that
Yeah.
one more time?
So there isn't really an income limit in Medi-Cal. Anything over the maintenance need gets determined to be a share of cost. So that was kind of the comment.
Yeah, and again, it's important to keep in mind, I think, that the income limits do differ for the general population. So children, infants, all the way up through adulthood through 64. But once somebody turns 65, there are those specific income limit criteria. And so we see the share of cost mostly impacting older adults disproportionately.
Gotcha. Thanks for that clarification.
Yeah.
Couple questions on a gap policy. One is asking, can you talk about the need for a gap plan? Another, how would things work with a Medigap or supplement policy?
Yeah, so Medigap policies and supplements can also get pretty complicated. And so, again, HICAP or any agency or resource that can provide some counseling on insurance options would be a great resource to go to. Dental, vision, a couple other things are not necessarily encompassed or included in Medicare. And so these gap plans would help supplement where there's a need that's not being met by Medicare A or B or C. So.
Okay, great. Let's see here. If you qualify for Medi-Cal, is it necessary to have a supplemental advantage plan like an Anthem Blue Cross?
Yeah, and it may not necessarily be, but again, getting some consultation and counseling would be helpful. And so there are many people who do qualify for both Medicare and Medi-Cal. And so that's what we call MediMedi. So you may hear that term being used. And for those that are MediMedi, the coverage is fairly comprehensive. And so one kicks in after another, one picks up where the other wouldn't. And so services are pretty comprehensive if somebody qualifies for both.
Okay, great. Is there a penalty for applying late for Medicare Plan D?
You know what? For Part D, I'm not entirely sure. I know there is for Part A and B. The Medicare website, can look a little much at first, but if you're able to get there and start clicking around, on every page they always link to another topic within that article, and so it takes you right to the next page that talks about that. So you should be able to find that information there. But if you can't, again, just call the helpline. We'll go through it with you, and we'll talk you through it and provide you some additional support and guidance.
Okay, great. A question about the VA benefit. Can you speak to that a little bit?
Yeah, so there are veterans who may qualify for a monthly pension. It depends on when they have served, where they served, and so there's pretty specific criteria. And so a person who already qualifies for a monthly VA pension may be able to also qualify for an additional monthly pension, and that's called the aid in attendance or the housebound benefits. So it's an additional allowance, and then that money would then be able to be put towards having hired help in the home. And so you have to have the VA pension first and foremost, but then you also have to meet at least one of a few varying criteria. It's generally you need to have some kind of dependence or be reliant and needing some assistance for some ADLs. If a person is bedbound or spends a lot of time in bed, then they may also qualify. If they're already residing in a skilled nursing facility, they may apply for that additional benefit. And the housebound benefit is a little bit different. And so to inquire about either of those benefits, it would be best to contact the VA. And there are some agencies and organizations throughout Orange County that offer assistance with navigating and applying for veterans benefits. So some of them may charge a fee, others may not. So just due diligence and researching and getting some feedback before you pursue any resources that are out there.
Great. Okay, what course can one take when someone's elder parent is otherwise healthy, except for dementia, and their Social Security income is $900, they own nothing, and have Medi-Cal? How do they get placed? Long-term care, since memory care facilities are private pay. Thank you.
Yeah. So I would encourage to call the helpline because, and I know I keep saying this, but it really is because our care consultants here have access to a lot of referral lists and resources that we can share with you. And one of those resources is our placement specialist. And what placement specialists will do is work with individuals and help them explore the different facilities, go on tours, and try to find a good fit. It is very challenging when the income is around that range, 900, or even if it's a little bit over that. As I shared earlier, the average cost of memory care or facilities is in the thousands of dollars a month. But it may just depend on the facility. You kind of never know. I've seen it work out for some people. And so again, just having that professional guidance and support can be helpful to at least start to explore, and then hopefully there would be something that would be a good fit.
Great. So you talked about a placement specialist. We had another question about geriatric care managers and what is their role exactly? What do they do?
Yeah, so geriatric care managers can be hired privately, and they're specially trained professionals who are there to provide coordination of care. So whatever it may be that there is a dilemma about, and so this is especially helpful if family members are living long distance perhaps and trying to help coordinate care for mom and dad or other relatives. And so they'll help kind of navigate a lot of the complexities of the things that come up over time as needs evolve. They'll come to the home, do home visits, family meetings, conferences, help draw up care plans so that everyone is on the same page about what the goals are, and then help adjust those goals and expectations as time goes on. And so it can be very, very helpful for an additional source of support. And we do have a referral list for geriatric case managers as well.
Great. We had a question about the look back period or the look back limit. Basically, what is the look back period when giving away or transferring assets?
The exact number of months is completely escaping my mind right now. I do apologize, but yeah, call the helpline and we can have someone look into it.
Someone just commented 30 months, possibly.
Yeah, it's a long time, and it is. 30 months is a long time. A lot can happen in 30 months. And so, again, just being very prudent about just planning ahead, not assuming that just giving away the money will solve everything. They'll look back at what transactions there were over the last those 30 months, and then that's a long time to wait. Yeah.
Yeah. Okay, here's kind of a question on a different theme. An older adult who needs help, who lives alone with no family. How do you go about approaching helping them? Maybe I'm assuming that this person might be a little hesitant to receiving some care, some help. Are there any strategies we can talk through?
Sure. And what we know is that especially for older adults who are living alone, and even more so if they might be starting to experience memory loss concerns or cognitive impairment, they're so fiercely protective of their independence, and rightfully so. There's still such a fear about and a stigma about not being able to stay home and age in place, and it's a desire that people have. And so I think really just taking it slow, genuinely offering yourself as a support system, just holding that space for them to open up and to share things, and getting familiar with the local resources. So senior centers and some cities in Orange County will have specific departments dedicated to senior services case management. A couple of the nonprofits in the local area may offer that kind of case management support. If you're ever concerned for the immediate health and safety or the welfare of somebody you know, it's Adult Protective Services is also a resource that's open to the public, and so they operate a 24-hour helpline where people can report concerns. But just kind of making yourself available to build that trust, it does take quite a lot of time. And sometimes they may be open perhaps to having like a friendly visitor in the home to start, and then they can kind of be a gateway to additional support and services.
Great. Here's another question about resources. Are there resources for boarding care facilities with multicultural staff? And I'm not sure if the question means, are the resources for the staff or are there resources for the community about these facilities?
Right.
So maybe either.
Yeah, and you know, the multicultural element, that need is so tremendous, and it's becoming more and more evident as time goes on. And so I'm bilingual Korean myself, and what I hear a lot from the Korean American community is that, you know, it's hard to send mom and dad or a loved one away to a facility where they're probably not going to get Korean home cooked meals or be able to communicate with other residents. And so whatever the language and culture is, we do see that challenge come up. I'm not really sure I have a good answer for that. Again, placement specialists and other professionals could help you try to do the research at least, so you're not alone doing all this research, and it's a lot of stress and planning and just trying to find information. I think there are more and more facilities that are opening up, but it is a tremendous endeavor to get a boarding care up and running and licensed and operating. And so hopefully we'll see more of those, you know, kind of multicultural, you know, boarding care facilities where there are bilingual staff and cultural elements that take into consideration what the residents need as well.
Absolutely.
Yeah.
So what are your thoughts on where should someone begin when looking for these types of services? It's a pretty nebulous thing to be dealing with, so any thoughts on a good starting point for someone?
Yeah. Again, if there are local senior centers or senior service resources, 211 through the county can also be helpful, or at least a good starting point. You can always call the helpline. And even if it's not Alzheimer's or dementia related, you know, sometimes we do get calls like that, and we'll try to help people, point people in the right direction. And so, I mean, there are services out there, but it's just like too much to kind of summarize in one encompassing point. So you can start with calling the helpline. You can start with 211, and just you know, it'll take you probably a lot more places than you'd like to before you get to your destination, but
Yeah.
kind of worth a starting point there.
Okay. And I'm not sure of the answer to this. We have so many resources over in the helpline. Do you have a list of companies who offer long-term care insurance plans, or would we be able to help with that?
We do not currently have a list of long-term care insurance companies. That said, if you do call us, we can try to point you in the right direction.
Okay, great. What is the cost of a geriatric care manager? I'm not sure if we have those figures available either. But...
No, for our referral list, we do have some figures.
Great.
So it won't speak to the entire population of geriatric case managers, but for the ones that are on our list, I think it's around the ballpark of maybe 100 to 120 an hour, and then there's like an initial consultation fee, which may or may not be, you know, discounted, or maybe like a free consultation. So it just depends on the individual who's practicing. But I think that's the general ballpark. Yeah.
Okay, great. And there was another question I'm missing where it went now. We've lots of questions about the qualifications that someone to be a geriatric care manager or case manager. I don't know if you could speak to the ones on our list at least, or the qualifications that they have.
Yeah. So
yeah.
Geriatric case managers are usually licensed nurses, so RNs, or licensed clinical social workers. And so I don't know the exact training requirements or certifications or everything that they have to go through, but usually nurses or social workers.
Yeah. Okay, great. And it's about 12:30. We do have a number of more questions. A lot of them are about very specific situations. So I just want everyone listening to know that we will respond to you. Hopefully by email, we'll be able to do that. And again, dead horse here, but you can always call our helpline. You can visit our website. We're more than happy to speak with you. We have lots of helpline staff who can spend a good amount of time with you on the phone, and they love to do that. So please give us a call. And again, if we didn't get to your question today, I do apologize. We had lots and lots of good questions. Just a final one, do you have a list of daycares near Irvine? I think we talked about that we do have some lists of adult daycares, right, that we could be able to send if you give our helpline a call. And I want to thank you again, Nikki. This was jam-packed with information, and I definitely learn a lot every time I hear this information again. There's just so much to know. I want to invite everyone to come to our webinar next month, which will be on March 10th. And it's going to be on understanding Alzheimer's disease in persons with Down syndrome by Eric Duran, who works at UCI Medical Center. He's fantastic, and so we do urge you to join us for that. Again, thank you to our sponsors. And as we exit this webinar, please watch out for that survey that will open up immediately, and go ahead and complete that if you want CE credits. Thank you everyone for joining us again. Thank you, Nikki, and we hope to see everyone next time. Thank you very much. Bye-bye.